Hematology Oncology, Intrinsic Hemolytic Anemias. All right, so the first thing that we're going to be touching in on is intrinsic hemolytic anemias. And once again, all that means is that there's something wrong with the red blood cell inherently, okay? There's something wrong with it, the functionality of it. It's not something outside that's causing it trouble. It's something specifically wrong with the red blood cell. Now, the first thing that we're going to be touching in on, the first pathology, is hereditary spherocytosis. What we need to know is that this is due to a defect in proteins that are helpful in maintaining the red blood cell membrane, skeleton, and plasma membrane. Okay, so it's really important to help maintain that shape. And so if we have a defect in those proteins that maintain the shape, also known as ankyrin and spectrin, those are the proteins that help maintain it. If they are defective, then we lose our biconcave shape of our red blood cells and they become small, rounded red blood cells and they lose their central pallor. So on peripheral blood smear, you're going to see spherocytes with no central pallor. Okay, and what you want to know on findings is that we're going to see an increase in MCHC. If you ever see an increase in MCHC, it's going to be hereditary spherocytosis. There is no other pathology that causes increase MCHC that we really care about right now for step one. So if you see increased MCHC on your CBC, know that it's going to be hereditary spherocytosis. Okay. Now, what happens? The body responds via the splenic macrophages clearing out these abnormal red blood cells. So the splenic macrophages are going to sense that these red blood cells are odd, they're not biconcave, so they're going to try to take them out. And this leads to splenomegaly, okay? Now, what we need to care about is that the patient is otherwise completely normal. So a way that we can cure this is we could take the spleen out. If we take the spleen out, the patient's going to be fine with just having these spherocytes floating around in their bloodstream. Now, the patient will still have those retained Hall-Jolly bodies from the beginning, which we talked about because the spleen is no longer available, but that's okay because everything else will be normal. Now, a way that we could test this, and something that they really like to talk about, it's high yield, is that you can do an osmotic fragility test. And this just shows how fragile these red blood cells are. Because we've lost the biconcave shape and they're very plump, it leads to an increase in fragility. So the red blood cells usually lyse with exposure to any hypotonic solution. If that occurs, then you know that you have a positive osmotic fragility test, and that shows that it's going to be hereditary spherocytosis. Okay. Moving on to the next pathology is going to be paroxysmal nocturnal hemoglobinuria. PNH is a short-term way to say it. Now, it's in the name. We get paroxysmal nocturnal hemoglobinuria. So the patient's probably going to be presenting with some type of hemoglobinuria at nighttime. And that's exactly what happens. So let's begin. Usually, when any patient that does not have this type of pathology goes to sleep, what happens is that when we go to bed, we start to have shallow breathing at night, okay? And that shallow breathing turns into respiratory acidosis. And the respiratory acidosis is likely to activate our complement system. But luckily for everyone that doesn't have this pathology, they have protection against these complement activation. However, patients with paroxysmal nocturnal hemoglobinuria, they don't have the ability to decrease that activation of the complement system. So the complement system is rampant and it starts to attack the red blood cells due to this respiratory acidotic state, leading to hemolysis. Okay? Now, what's the pathophysiology behind this? Well, the patient, once they go to bed, they have impaired glycoprotein anchor system. Okay, so these are GPIs. They have an impaired GPI, which holds decay accelerating factor, DAF, also known as CD55. Okay, I know that's a lot coming at you, but all you really need to know is that these patients lack glycoprotein GPI, which normally holds DAF or CD55, the same thing. DAF and CD55 are the same thing. Okay, now, those normally protect the red blood cell membranes from any complements. But if they don't have the GPI to hold the DAF and the CD55, then they don't have protection against the complements and they get hemolysis. Now, the patient's going to present in the morning, they're going to have pink/red urine. Okay. So it's always going to be someone, not always, but majority of the time, it's going to be a kid or someone that's going to present to the doctor's office with urination that's darker in the morning. Okay. And then they're going to do some labs. They're going to find that they have CD55, 59 negative on red blood cells on flow cytometry. And what we're going to be asking, or what they might ask, is a common cause of death. And this patient's going to have venous thrombosis. So they have the main cause of death is Budd-Chiari syndrome, which is just a thrombosis within the hepatic vein, which we'll get to later on in the GI section. But what we just need to know for PNH, just a quick overview, The patient lacks GPI, which holds DAF and CD55, meaning that they cannot get rid of the complement system. So the complement system goes rampant. It destroys the red blood cells in times of respiratory acidosis at night when we're shallow breathing, and it leads to pink and red urine in the morning and hemolytic anemia. The way that we treat this is that we're going to give the patient eculizumab, which is just a complement inhibitor, a late complement inhibitor, C5 inhibitor. All right. Next, the next pathology is going to be G6PD deficiency. I'm sure you've heard of this so many times in your studies for M1 year and now M2 year, it's coming back. This is very, very high yield, something that you have to understand. So, overview. It's an X-linked recessive disease, and what we have to understand is that we have a G6PD defect. And that defect in that enzyme of G6PD leads to a decrease in the ability to produce NADPH. Without NADPH, we lose the ability to reduce glutathione. Now, glutathione is important because we need reduced glutathione in order to get rid of reactive oxygenated species. So without this reduced glutathione, it leads to an increase in red blood cell susceptibility to oxidative stress, especially in times when patients take anything that causes oxidative stress. For example, fava beans is one of their favorite things to ask. Anti-malarias is also another thing. Okay? Very important to understand this. How does a patient present? If you ever see a patient with back pain, they get any type of jaundice, okay, and they have hemoglobinuria a few days after maybe eating the fava beans, then you know that you're going to have to deal with G6PD. And the highest yield association with this is that since we have a decrease in G6PD activity, we're going to get these things known as Heinz bodies. All Heinz bodies are just aggregates of hemoglobin. And the way that this works is that we're going to see those Heinz bodies by the splenic macrophages, and they're going to take a bite out of those red blood cells in order to get rid of those aggregations and get rid of those Heinz bodies. So that's what we're going to see on peripheral blood smear, those bite cells. All right. Moving forward, and most importantly, we have sickle cell anemia. Sickle cell anemia is due to the fact that we have a point mutation in the beta globin gene. Okay. And this is going to be a glutamic acid to valine change, okay, mutation at the 6th position. They love to ask this, understand this fully, you'll be able to get so many things, okay? Now, what does that do? If we change glutamic acid to valine at the 6th position, who cares? It sounds like it's not the big end of the world. Well, what happens is that it alters the hydrophobic region on the beta globulin gene, and it causes sickling of red blood cells in times of low oxygen levels. Now, this is bad because once we have sickling of red blood cells, we have an inability to get through the vasculature. Like, think about capillaries, they're so small. If we have sickles rather than biconcave shape, then they're going to get stuck in those capillaries. They're going to get stuck in those small arteries and in those small veins, and it causes vaso-occlusive episodes. So this is why it's known as a vaso-occlusive disease, okay? And that leads to the complications that we're going to see. The first thing that we see is autosplenectomy. And what does that mean? We have so many different blockages within the spleen, okay, because it's a vaso-occlusive disease and we start to sickle in times of low O2, we start to block that blood supply to the spleen. And so we get all these small little infarcts within the spleen, making it completely unable to do its job. So that's why it's known as autosplenectomy. It essentially kills its own spleen. So this leads to, once again, Howell Jolly bodies on peripheral blood smear, but also an increased risk of infection by encapsulated organisms. We know that when patients have asplenia, any type of patient that loses their spleen, whether it might be autosplenectomy or it's just taken out or it ruptures randomly, anytime that the spleen is gone, we have to worry about encapsulated organisms attacking the host, because the spleen normally gets rid of those encapsulated organisms. And a way that we can remember the encapsulated organisms that are important is SHIN. Okay, SHIN. Okay, so strep pneumo, Haemophilus influenza, and Neisseria are the main bacteria that we need to worry about for autosplenectomy. Next, we're going to have painful vaso-occlusive episodes. If you ever see a child that comes in, they have severe pain in their fingers and in their toes, in their hands, in their feet. They have dactylitis. That means that they most likely have sickle cell disease. If they have recurrent times presenting to the ER with these painful episodes, then first thing that you should be thinking about is sickle cell disease. The only time that they'll say they come in every single time with painful hands, painful, abdomen, painful feet, and they were just treated with analgesics and rehydration and they were sent home. Then you know that you're dealing with sickle cell anemia. It's one of the most common things that they like to present with, okay? Next is sickling in the renal medulla. So in the renal medulla, that means just at the center of the kidney, we have very low O2 levels. So we're going to have sickling there and it can lead to hematuria, okay? Now, a way that we could help prevent this from occurring in patients, especially in newborns, is that we want to keep hemoglobin F present. Okay, so as we discussed earlier on in the chapter of hematology oncology, hemoglobin F is usually gone by the time that we're like 6 months old. And then that's when the patient starts to present with the symptoms because he's lost or she's lost all of their hemoglobin F. Okay, so if the HbF is gone, that means HbS, which is hemoglobin sickle cell, is the new thing that's intact. And so we can't really help the patient after that's occurred. But what we can do is provide the patient with hydroxyurea. And what hydroxyurea does is that it just allows for the continued presence of HbF, fetal hemoglobin, to stay present. It's the most important thing to understand is that hydroxyurea will just keep levels of HbF high within the newborns so that they don't present with increased levels of hemoglobin sickle cell, HbS, later on in life. On peripheral blood smear, it's a giveaway if you see sickle cells, but also make sure to keep an eye out for target cells. Lastly, and somewhat low yield is hemoglobin C disease, HBC disease, okay? And the way that I remember this is just your C's. HBC disease is going to have glutamic acid to lysine, C in the lysine is the way that we remember it. And you're also going to have crystals inside the red blood cells, C for crystals inside the red blood cells. You're also going to have target cells there.